Well, welcome everybody. Thank you for joining us today. My name is Amanda Schellinger, and I work with the National Kidney Foundation of Wisconsin. Today's topic is Dialysis 101. I'd just like to take a few seconds to talk about who National Kidney Foundation of Wisconsin is. So, National Kidney Foundation of Wisconsin is a nonprofit organization that is dedicated to preventing kidney diseases, improving the health and well-being of individuals and families affected by kidney disease, and increasing the availability of all organs for transplantation. So we do that through professional education, patient education, increasing awareness, advocacy efforts, and then providing free services such as our community kidney screenings that are free and our medical ID jewelry program. I just wanted to call your attention as well to some other National Kidney Foundation of Wisconsin upcoming events. For our professionals that are in renal healthcare, we do have a renal professional education conference happening in Madison on November 16th. Registration is open, so I encourage you to check that out. For patients, we do have our Living Donors Together group that meets quarterly. They're actually meeting tomorrow if you'd like to join us. Otherwise, we'll have another meeting in January. And then we also have 2 additional webinars coming up similar to this format. One is on eating for stage 3 CKD. That one will be in December. And then we have hypertension and kidney health, which will be happening in early February. Lastly, we will be having a National Kidney Foundation of Wisconsin virtual town hall that will be happening on Tuesday, November 28th. It's just a great forum to come hear what we've been doing in the community and ask any questions or share any concerns, things like that. So definitely encourage you guys to go ahead and check that out. You can feel free to follow up with me after this meeting. Otherwise, you can find out more at kidneywi.org. So with that, I will turn it over to our presenters, Dr. Batool and Dr. Ayoub.
Hello, everyone. Good afternoon. My name is Dr. Batool. I'm nephrology fellow at Medical College of Wisconsin. And here's my attending, Dr. Ayoub.
Hi, everybody. Looking forward to chatting with you all today. We're hoping to give you a little bit about dialysis and a quick little crash course. And just wanted to outline some of our learning objectives here before I let Dr. Batool take over. So just briefly, we'll be talking about timing of dialysis, what different types of dialysis there are, how to prepare for dialysis, the details of dialysis itself, benefits of it, risks of it, and alternatives in some cases to dialysis. So let me just figure out how I can skip to the next slide now.
You should be able to click, otherwise you can use the arrows on your keyboard.
There we go. Okay. All right.
So everyone who is here today, there is a reason that you are here. Either you or your loved one or a family member or a friend is dealing with an organ failure or is going to deal with an organ failure, and you heard about dialysis, and that's why you are here to learn more about it. Even though it's called Dialysis 101, I would like you to grab your pen and paper because there are going to be some information here that you may want to write it. Why do we do dialysis? It's a mutual decision between you and your doctor to determine when you should start dialysis based on several factors. One major factor we as physicians look at and also encourage our patients to talk about and be more expressive about is overall health. How you are doing generally. Are you able to get through your day-to-day life? Or is an organ failure, that is the kidney disease, hindering the way you live your life? Kidney functions. As much as we as nephrologists like to talk about numbers, when it comes to dialysis, it's not just about the numbers, but sometimes it does. Sometimes the numbers are just way abnormal and it threatens your life, and then we are like, okay, let's go for it. Signs and symptoms of toxin accumulation. When kidney function declines gradually, there are certain toxins that kidneys clean, and then they start to accumulate, namely, most commonly, the one that is measured is urea. And then there are signs and symptoms from the toxins, which include lethargy, lack of energy, lack of appetite, inability to focus. Sometimes the toxin accumulation can cause accumulation of fluid around the heart, and we consider that an emergency. Um, and then abnormal electrolytes. Potassium is an electrolyte which is a very primal to the function of many body organs, but most importantly, heart. And so, if potassium levels are uncontrolled and they are very high, and we are not able to control that with the help of diet and with the help of medications, then that is one reason we do start dialysis. Quality of life. Some patients prefer that quality of life might change when they start dialysis. You are investing quite a good portion of your life hours into the process of dialysis. And many patients, they would be able to get that time to be able to live. However, there are some patients who I have taken care of who would rather prefer not to have dialysis. Personal preferences. Um, that is something that play a major role more so into the modality that we choose as to what type of dialysis would you like to have, and that also calls into quality of life. Where would you like to get dialysis in a center, or would you like to get dialysis at home? Are you able to do your dialysis at home? Do you have the help that you are going to need? Would you be able to acquire the skills that you need? So basically, to answer the question why it's done, it's there are many reasons it's done, not one. One thing I would like to say is dialysis machines. They are engineered to be safe, reliable, and predictable. They are engineered to deliver exactly the same prescription that we put in there, that we as kidney physicians, as nephrologists order. Humans, on the other hand, everyone is unique. Even same person may respond differently to same stimulus on different days at different times. So each individual's experience with dialysis is going to be different. Even certain dialysis sessions are going to be more fatiguing, and certain dialysis sessions you will walk out and you will feel lighter or better. And some dialysis session it might take you a day or two to recover, and some dialysis sessions you may feel some symptoms of cramping or lightheadedness. But it depends. Everyone is different. What to expect? Um, You can receive hemodialysis in a dialysis center, at home, or in a hospital. The frequency of treatment varies depending on your situation. Simpler hemodialysis machines have been made for home hemodialysis, and they make the procedure less cumbersome. So, with special training and someone to help you, you may be able to do your hemodialysis at home. You may even be able to do the procedure at night while you sleep. There are dialysis centers located throughout the United States and in some other countries as well. So you can even travel to many areas and still receive your hemodialysis on schedule. Your dialysis team can help you make appointment at other locations outside of the US as well. Hemodialysis can be done in center. Many people get hemodialysis 3 times a week in sessions of 3 to 5 hours. 5 hours is calling it the longer edge. 3 hour is calling it to the shorter edge. Most of the people generally get 3.5 to 4 hours. But yes, that is the range that I see them getting. Daily hemodialysis. Daily hemodialysis, more frequent but shorter sessions, usually performed at home 6 or 7 days a week, about 2 hours each time. Peritoneal dialysis. This is the dialysis which is done through a soft catheter which is placed in your stomach. And this is done at home. Now, hemodialysis and peritoneal dialysis, even though you are getting it at baseline when you are stable, when you get admitted to the hospital or to a nursing home, hospitals are well capable of carrying out both the procedures, so they would be able to accommodate both. Long-term care facilities, nursing homes have facility to perform either or they would have a unit closer to them where you can get your hemodialysis. There are cruise ships which have hemodialysis facilities on them. So there are patients who do home hemodialysis and they can carry, there are patients who do home peritoneal dialysis and they can carry their PD machine, the cycler, with them and travel. This is what a hemodialysis machine looks like. I don't think all the parts and the mechanics, even I know all of them, but the major thing is the big screen, the blue one, has all your numbers on it. Your blood pressure, the machine checks your blood pressure every so often. There is a filter that is the dialyzer, the longer object to the right. And then there is dialysis solution in a canister in the bottom, and then also on the side. Some units may not have those. They would only have the solution coming from the back, and you may not see all those stuff in the front. But that is the basic dialysis machine in a center or in a hospital.
So just to emphasize, if you ended up doing dialysis at home, this is not the same machine that you'd use at home. The machine that we have here on screen is the one that you would see in the hospital, in the emergency room, in the ICU, and the regular floors. If you were to do dialysis while you were in the hospital or a long-term care facility, this is the kind of machine they would typically use. So don't be too intimidated by the size. This is not the same one that you would end up doing if you did home hemodialysis.
How you prepare? I know we did receive a question beforehand about how to prepare for hemodialysis. Preparation for hemodialysis is a stepwise process. A main thing we talk about when we say prepare for hemodialysis is, are you mentally prepared? Are you physically prepared? When we talk about physical preparation, we mean, do you have the access? Do you have an access in your body that we would be able to attach the machine to? Or do you have the access for hemodialysis or peritoneal dialysis, which will bring us to our next topic of what the accesses are. But I just want you to know what the access does is it kind of removes small amount of blood from your circulation into the machine, cleanses it, and then it gets returned into your body.
So in a sense, it's the point of connection between you and the dialysis machine. So Dr. Batool is going to talk about briefly just the different types of dialysis access. And again, when we say access, that means how is the machine going to be hooked up to you? Is it going to be through a catheter, meaning like that piece of plastic that they would place into your vein to be able to connect you to the machine? Or is it going to be something surgical inside of your body using your own blood vessels that then a nurse could poke and connect you to the dialysis machine that way?
So it could be a catheter, it could be a fistula, or it could be a graft. I know we received questions regarding the access, so I would like to talk a little bit more about it. Arteriovenous fistula. Basically, what we do is that's where we use our surgeon's help, who help us create what we call a connection of the arteries and the veins in the body. So this surgical procedure is considered a minor surgical procedure. You get discharged the next day. However, arteriovenous fistula takes an average 6 to 12 weeks to get matured. And in some patients, it even gets longer to mature. When I say mature, I mean ready to use. So main reason that it takes that time is when we connect the artery and the vein, we want the vein and the artery, both of them, to get bigger so that we have a connection where we can take the blood out from one side, clean it, and return it in the circulation through the vein. This is a picture of an AV fistula, which is cannulated. And you can see that there are bandages and there are tubings, and you're like, what are we talking about? So basically, at one point, the needle is going in and is taped in securely in place, and that is getting the blood out into the machine. And when the machine cleanses it, the other tubing is returning the blood into the vein through another needle, which is also secured in place. And all of these tubings are secured in place, so that even while you move or do anything with that particular arm, the needles are secured safely in place. Graft. Graft is artificial material.
Sorry.
So graft is it's a synthetic material placed by the surgeon inside your vein to make the same connection of the artery and the vein. Which one do we prefer? Depends what you need. You need dialysis urgently. The best way for me to do it is by putting this catheter, central venous catheter, into your neck so that I can deliver the dialysis right away. It's ready to use right away. The moment it's placed, we can use it within minutes. However, if we have the liberty of time where we have a few months, you are in stage 5, so we would get you a fistula. And if fistula fails to mature, then we can ask our surgeon to maybe work around with fistula, reconstruct it, or maybe get you a graft. Why are we creating a fistula and a graft when we can just easily place a catheter and it would be good to go? Catheters have high risk of infections. Number one, they are a foreign body attached inside your body. It's a catheter that goes in from the neck into the right side of your heart. It is covered, it's under the skin, and there's a dressing on top of it. You can shower with it. It's not visible to people. You put your shirt on it, nobody would know you have it, so it's not very obvious that you have it. But it carries very high risk of infection, so we like to avoid it if we can. Procedure. What happens when you arrive for the dialysis procedure? You would enter this really nice dialysis unit, which would be cleaned. You would be greeted by a very nice receptionist. There is no music, I'm sorry, but you will have your own TV and you can put some music on. But before you do that, your weight, blood pressure, pulse, and temperature will be checked. The skin covering your access site will be checked. So the point where you have your fistula or your graft or your catheter would be checked and would be cleansed. During the treatment, most of the units have these recliners where you can recline or sit in the chair. Most of the time, you would hear your nephrologist or social worker say, "Dialysis chair. Let me get you a dialysis chair in a unit." That's what they refer to get that particular recliner assigned to your name for that particular hours of the day. So they would sit you nice and comfortably in your chair, and then they would access your access, which will be cannulated with the help of the needles and the tubings, and the machine will be attached. And you can use the time while you are attached to the machine to watch TV or movie or read or nap, or you can talk to your neighbors if you like them, or you can pull up your curtain if you don't like them. This is a video. Let's just hope that it plays. So this is the dialysis machine running. You can see the center part that looks like a wheel and it's moving. That is called the pump. What the pump is doing is it's getting your blood out from your body, few ml at a time, about 300 to 400 cc at a time, circulating it through the circuit, which passes through the filter, get cleansed, and gets returned to your body. The screen over there is a very sophisticated screen, which is showing us a lot of numbers. Those numbers mean a lot to us. Every single number has a meaning. Every single number tells me how well your dialysis session is going, how much water is getting pulled out of your body, what are the pressures inside the access. I can see your arterial pressure, your venous pressure. I can see your blood pressure, the temperature of your blood, how much total fluid I'm going to take out. And basically that is the running commentary of your dialysis treatment. Um, we talked about the procedure. During the dialysis procedure, we continue to monitor your blood pressure, your pulse, and a lot of numbers without you even knowing about it. But also, you would see the dialysis tech come in and check on you and ask you every now and then as to how you are feeling. Um, some patients who have diabetes and need their finger sticks checked, they don't have to bring their own equipment. Dialysis staff is well equipped to do that, and they do that in the unit for you to check how you are doing. If you're not feeling well, you're like, can you check my blood sugar, by the way? Um, the other thing we can do during dialysis is we can draw your labs. We usually like to draw labs while our patient is attached to the machine to prevent another stick, another needle stick to you. So there are some labs that we draw routinely. So you can expect some labs to be drawn during the procedure. Once you finish the procedure, the needles would be removed, a pressure dressing would be applied, and then they will take your weight at the end of the procedure, and then you will be all ready to go on your way home. Um, between the treatments, what is it that you can do to help us, your team, achieve the best results possible? If you eat the right food, take your medications as prescribed, allow your team to assist you by discussing your concerns. I would say it again. You have any concerns, please do not hesitate. Let your dialysis team know. You have a dialysis tech there, you have a dialysis nurse there, you have a dialysis MD who would be seeing you once or twice or maybe more often in a month. What happens? What are the things you can experience as a part of the end stage renal disease along with being on dialysis? The symptoms you feel when you are getting dialysis, they may not all be coming from the process of dialysis. Some of them might be from having end stage renal disease. Um, so it's sometimes hard to differentiate if the symptoms are coming from the dialysis procedure or if they are coming from the end stage renal disease. When the dialysis procedure happens and we are trying to take the fluid out, because see, in normally functioning kidneys, you are making urine. Now that outflow of the water or the fluid is gone. So we are removing the fluid during the session, not just the toxins. We are also taking out extra water off of you. When we remove that fluid off of you, you can or you may experience low blood pressure. You can experience some cramps, itching. Some patients experience itching just as a part of the end stage renal disease because there are toxins which accumulate in the body. Some patients experience itching during the procedure of dialysis. Itching is a symptom that there is ongoing research on itching in end stage renal disease. But the more dialysis you get, hopefully more toxins will be removed and hopefully itching would be better. Sleep problems. There is a lot of research on sleep problems in dialysis patients. Usually, it's reported that patients who get home dialysis they sleep better. But sleep is something that we would expect somebody who is on dialysis probably has so many other comorbidities. So sleep is a very complicated issue in that regards. Anemia. Kidney synthesizes a hormone called erythropoietin. When kidneys are not functioning to the very 100%, there is lack of that hormone. And hence there is decreased synthesis of blood in the body. When our patients go into the advanced stage of chronic kidney disease, which is stage 4 or stage 5, many a times they need supplement of the hormone. So many of the patients are already familiar with the concept of anemia. Many of them are familiar with the injections that they get for anemia. The good part about being on dialysis and anemia treatment is that you get all your anemia treatment while you are attached to the machine. You will get your hormone injection, you will get your IV iron infusions while you are on the machine. So anemia is not really a side effect of dialysis, it's just a part of the end stage renal disease spectrum, but it gets treated during the dialysis, and it is responsibility of your dialysis team to treat it. What I would say is that please let your team know that if you're feeling short of breath or lightheaded and you don't feel too good, let them know, because I recently had the same experience where one of my patients, he said, I don't feel too good today. And I look at him and he's pale. We draw his hemoglobin, it was low, and we ended up giving him a unit of blood. So watch for your symptoms. Bone disease. Kidneys play a great role in keeping healthy bones. Bone mineral disease is a problem of advancing chronic kidney disease. So your bone disease would be treated during the dialysis process. There are certain formulations of vitamin D that can be and are administered during the procedure of dialysis. One major thing to affect bone issues are the phosphorus levels. As the kidney function declines and the bones, they start to resorb, because kidney is synthesizing the good active vitamin D for you. Kidney is helping your body absorb calcium in your diet. But also, when kidney is not functioning to the very best, you end up absorbing a lot of phosphorus, and every food has phosphorus in it. And you would probably, towards the advancing CKD, towards the end stages of CKD, stage 4 and stage 5, we as nephrologists would be advising our patients to not consume diets higher in phosphorus. And then we would sometimes start phos binders, that would be the tablets that you would be taking with your meals. Even in stage 5, we might start those sometimes. Dialysis process itself clears some of the phosphorus. However, the one from the diet, the only way to control that is to take a phos binder with the first bite of food. High blood pressure, hypertension. Hypertension sometimes is the reason that you end up on dialysis, that you get the chronic kidney disease and eventually end stage renal disease. But also, high blood pressure might go hand in hand with fluid overload. In our dialysis patients, if they don't watch, if you don't watch your salt intake, that is going to make you feel thirsty. That's what the salt does, and it's hidden in every diet that we eat. It's going to make you thirsty. You might end up drinking a lot of water, and you might gain a lot of water. Higher the amount of fluid is in your body, your blood pressure can go high. So yes, it could be chicken or the egg, which came first. It could be it could already be present on your body and could worse when you gain more fluid. Potassium. High potassium levels are the problem of patients on hemodialysis. Our machines are very well controlled. We can change our dialysis fluid potassium concentration to help you achieve an ideal level in blood. But the best way to control your potassium is by eating right amount of food. Low potassium levels. There are some patients where potassium levels are low. Most of those patients are the ones who are on home hemo or the ones who are on peritoneal dialysis, where their potassium levels are low. Most of our hemodialysis patient potassium, we are able to keep it in a very within the range. Access site complications. Many things can happen to the access site. As we talked about the catheters can develop infections, which sometimes are visible to you on the skin and sometimes not visible to you. They are internally under bloodstream infections. Your AV fistulas can get blood clot. Your AV arteriovenous, the graft, can get blood clots. You can get what we call aneurysm or dilatation of the fistula or the graft. So basically what that means is, with repeated sessions of dialysis, if we put needle in the exact same spot, we can weaken that part of the blood vessel, and it can make kind of a balloon which you can see from the outside. But that is something we, your dialysis team, keep a good eye on and watch it very closely.
So at the end, I'm sure many of you will probably have a lot of questions about these. So at the end, we'll make sure that we address a lot of these. I did want to just double back and just reiterate something Dr. Batool said, in that a lot of these symptoms, it's hard to tell in most patients whether or not it's because of the dialysis versus is it because of the fact that they have these symptoms because of their kidney failure. Many of these on the screen, like itching, your blood pressure, your fluid overload, your sleep problems, can all improve with dialysis, meaning that the itching will get better, the sleep will get better, your fluid, meaning how much water is on your body. Sometimes people feel a lot of water in their legs, puffiness in their legs. All those things can improve with dialysis. But some other things are some things that we have to keep in mind with patients on dialysis, like Dr. Batool said, with the axis site complications, infections, things like that. Sometimes people who are on the machine feel some muscle cramps. Sometimes they feel like their blood pressure is a little bit low, and sometimes their blood pressure does get low. So these are just some things that you might hear when you're getting the process going to start on dialysis. These are some of the things your care teams is going to bring up to you about. All right. So I think that most of our questions we got were from people who I think are kind of setting up for dialysis in the future. It sounds like they know that their kidneys are heading in the wrong direction, unfortunately. But there is a group of people that are what's considered urgent start hemodialysis. And these are the people that, unfortunately, for whatever reason, they're in the hospital or they're at home, they're not feeling too well. Their care team checks their blood tests, checks their urine tests, and it looks like now, unfortunately, they have what's called an acute kidney injury, which means that the kidney numbers are not looking great. The kidney's not really doing its job anymore. The kidneys aren't clearing out toxins. They're not managing electrolytes. They're not making much urine. And then this is what we say this person might end up needing to urgently start dialysis. Your kidneys can shut down after a severe illness, complicated surgery, a heart attack, any serious problem. I like to tell patients in clinic that the kidneys are wimps. The minute anything happens in the body, the kidneys are almost always the first to freak out and stop working the way that they should work. So in certain patients, they need to have hemodialysis started urgently, meaning, we don't have the luxury of waiting a couple months and seeing what happens. For whatever reason, the blood numbers look really bad, and we can't just kind of wait around for it. People who are higher risk for something like this are like many of you who are in the audience today, where your kidney function at baseline was not great. It was better in the past, but maybe now the percent functions around 30%, 20% already. And then something kind of tips you over the edge in the hospital or outside the hospital. And now, unfortunately, we're in a situation where we don't have the luxury of waiting for a while to start dialysis. We have to start right away. Not everybody ends up needing to stay on dialysis in these situations. Say the person who's reasonably healthy, their kidney percent function 60%, something happens in the hospital, they need dialysis. There's a chance for recovery in those situations, and that the person doesn't need to be on dialysis the rest of their lives because their kidney function at baseline was okay. But unfortunately, like I said, many of you already kind of are going into this knowing that your kidney percent function is not great. So if you come into a hospital with 20% kidney function, 10% kidney function, and something were to happen, then it's unlikely that your kidneys would be able to recover back and get off dialysis. Unfortunately, like I said, think of it kind of as you've reached a tipping point and now you're over the edge. So in those patients, we would end up needing to urgently start dialysis on them. But thankfully, many of you are coming in because you want to prevent that, right? You want to prevent the whole, it's 2:00 in the morning and now there's a catheter in my neck and I'm in the ER and I started dialysis. So of the things that we're talking about today is starting dialysis in a controlled, calm setting and not in the emergency room at 2:00 in the morning. And one of the modalities I wanted to talk about today with Dr. Batool was home dialysis. I think this is becoming more and more popular now in the United States. To put it in comparison, there's home dialysis and what we call in-center dialysis. So the in-center dialysis is the one where you might hear terms like Monday, Wednesday, Friday, Tuesday, Thursday, Saturday, a dialysis chair like Dr. Batool was mentioning. Home dialysis, on the other hand, is just that. It's dialysis that you would do at home. There's a lot of pros and cons to both, obviously, but I think some of the pros that probably will be more appealing to many of you here is, the quality of life, the increased feeling of well-being, the reduced symptoms and cramping and nausea that comes with the 3 times a week, a little more aggressive dialysis. The nice thing about home dialysis is that you're kind of in control of it in a lot of ways. And because of that, we can do the dialysis more frequently during the week. And then because it's more frequent, the sessions can be a little bit shorter in a lot of ways and a lot more gentle in a lot of ways than just the 3 times a week in the center hemodialysis. The nice thing about it as well is that even though it's at home, we're still going to be monitoring you the same way that you get monitored in center. So your care team is going to be following you to make sure that you're getting the right amount of hemodialysis to get all the waste out of your blood. They still check your weight, your blood pressures very closely. A lot of this actually is through the machine directly. So the machine will check your blood pressure and just communicate it to us digitally. And then we'll be able to check blood tests to measure all the clearance and all the things that we need to do to make sure, like I said, that your body is getting all the toxins removed. And we can actually also measure how well your access site is doing through the home dialysis. Like I said, there's a lot of pros and cons, but just know that if you end up pursuing home dialysis, all the same way your care team can adjust hemodialysis intensity, frequency, monitor test results, all that can still be done with home modalities as well. Oops. So with regards to home hemodialysis, that's like the one we saw in the video earlier. That one's called hemodialysis, which means blood dialysis. Like I said earlier, the machine's not as big. I think we might have a picture of it, the home one, but the machine's a bit smaller. But because it's blood dialysis, the training is a little bit more intense, and not everybody is the best candidate for it. So typically we make sure that patients get trained for about 30 hours or so. Now, obviously that's not 30 consecutive hours. We're not going to hold you hostage in the dialysis unit until you learn how to do it. But think of it like a course. So you have to pass a course and you have to log at least 30 hours in this course and be able to demonstrate to us that, you'd be able to manage the machine yourself and have a care system, hopefully, that could help you with that. Some other things people don't tend to think about is your plumbing. Dialysis requires a lot of water, so not everybody's accommodations at home are suitable for home hemodialysis. So that would be another thing. Your house, your apartment, your condo, whatever, would get assessed by your team to see whether or not it's suitable, if there's anything they could change to make it suitable, or if it's just not really going to work, it's not going to be suitable at all. Like I said earlier, with regards to monitoring, your dialysis care team is going to monitor your treatment, make sure you're getting the right kind of hemodialysis, make sure that your blood tests are being measured. These are some terms that we use here. Don't worry too much about these terms, but you might hear these words in the future. Things like urea reduction ratio, URR, or KT over V. These are words that your nephrologist and your care team are going to use. And essentially what these are just blood tests that we'll be checking to make sure that your body is clearing out the toxins it's supposed to based on how well the machine's working. So hemodialysis, blood dialysis, is not the only at-home dialysis modality that we have. So there's something called peritoneal dialysis. This is the machine for peritoneal dialysis. And as you can see, it's a lot weirder looking, a lot more old school looking than the hemodialysis machines that you saw earlier with the pump and the circuit and the whole thing. To put in perspective, this is the peritoneal dialysis cart. So I'm about 6'1". This cart here at this line would maybe reach my hip. So they're not really massive machines. And what peritoneal dialysis is it's essentially a modality of dialysis where a small catheter, well, not small, I should say, but a thin catheter is placed into your belly, and it's a minor surgery done by a surgeon, and then you do your dialysis through this catheter. Like I said, this catheter is so you could do dialysis at home. So you would be responsible for keeping it clean, hooking yourself up to the machine, and making sure that it's running well. Obviously, your team would be involved in every step of the way, but at the end of the day, at home, you're the one who's going to be hooking yourself up. So what happens with this dialysis modality compared to the other one is that you're essentially cleaning your blood through this catheter in your belly by putting in what's called dialysate. The dialysate goes from the machine through the catheter into your belly and just sits there for a bit and then comes back out, drains back out, and by doing that, takes out all the toxins with it. When it comes to the training and how to do it, it's kind of like the other thing we were talking about, where there's a course involved. Your dialysis center will teach you everything that you need to know, how to do what's called the exchange, meaning how to put the fluid in, get the fluid out, how to order supplies like the bags of fluid at your home, because you'll need those, how to clean the catheter, how to make sure you're protecting yourself against infections. So the first couple sessions, you'll be doing them in the center with your staff there so that they see how you do it. And then once they feel comfortable for you to do it at home alone, you start doing treatments alone at home. So like I had said earlier, this is another way to do home dialysis so that you don't necessarily have to come into a center Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, be hooked up to a machine, that sort of thing. But just know, obviously, like I'm trying to emphasize, yes, you'll have that freedom of doing it yourself at home, but you're doing it yourself. And we will train you, we'll do the best that we can, but you have to be comfortable with knowing that I'm responsible for this at the end of the day. And we have to, as a team, be able to trust each other that it's going to go smoothly and that you'll listen to us and do your dialysis at home. So are there different types of peritoneal dialysis? There are. I won't go too in depth into these, but there's what's called continuous ambulatory peritoneal dialysis, CAPD, and continuous cycling peritoneal dialysis, CCPD. With CAPD, you're kind of doing the exchange yourself, meaning that you hook yourself up to the machine, you make the machine draw fluid, what have you. In some instances, there is no machine, and you just do it yourself, bags wise with the catheter. But then
you hang it up.
Yeah, exactly.
You have a scale, the old school scale that you zero the scale, you hang it up, and then it puts the fluid into your body, and then you cap it, disconnect, go about your day. You can do clean your house, cook, do whatever, and then after 2 or 3 hours, you just drain it all out, and then you put more in, and then you go about your day, because not everybody would like to get hooked to the cycler. So yes, CAPD is an option, and is kind of famous in other parts of the world. We here do a lot of CCPD.
Yes.
Where we have a cycler, the machine that we showed you earlier, which would be next to your nightstand. You go to bed, you hook yourself up to the machine, you lay in your bed, read for a couple of hours, go to sleep, you wake up in the morning, your dialysis is done. You unhook yourself and you go about your day. Sometimes even with the cycler, we may need like maybe one more fill or maybe 2 more fills, but that doesn't happen with every patient, but that is a possibility that might come into discussion.
So just a brief summary of the two different types. There's the one where the machine is hooked up to you all night and does everything for you, which is the CCPD. And then there's the CAPD, where you're not hooked up to the machine all night necessarily, but then it's a little bit more involved from your part, whereby you're hooking it up to yourself, the bag wise, and draining it into yourself, then draining it out. So that's where the term ambulatory comes from. Ambulatory is a fancy word for walking, so that you can, fill the fluid, walk around for a bit, and then drain it later.
Just don't go to gym with it in the bed.
We'll talk about that later. All right. So then diet-wise, Dr. Batool had touched on it a bit, but when it comes to kidneys, we want to be able to control the things we can control, right? Because at the end of the day, unfortunately, you're all here because you or somebody your kidney percent function just, wasn't getting better despite everything you guys were trying, despite everything that your doctors were trying. So what can we control? We can control our diets, right? So this is something we like to talk about a lot, because I think it empowers you as a patient to be able to take control of the situation, right? Because we can do all the dialysis we want, but at the end of the day, if you, as our coach, you're not, eating the right amounts of salt, right amounts of potassium, right amounts of phosphorus, then we're going to be fighting a losing battle, right? So it's very important to get the right nutrients and vitamins that you're supposed to. Make sure that you're still eating adequate amounts of protein and a healthy diet. But B, I think very importantly, that a lot of people don't realize is that we have to kind of watch how much fluids we're taking in. So, although that a lot of people think that, I have kidney problems, I got to make sure I drink as much water as possible. That's not really a blanket idea for all kidney patients, right? Yes, some patients in unique situations need to be drinking a lot of water, but a lot of times we actually need the opposite, right? We need you to not exceed a certain amount of fluids every day. Because if you think about it, all that fluid that you're drinking is just going to build up somewhere, and then we have to take it off with dialysis. And kind of along the same lines, sodium, which is a fancy word for salt, is going to be your biggest thing that you need to watch for moving forward. Sodium, like you all I'm sure know, can cause high blood pressure, can cause heart attacks, can cause strokes if you eat way too much of it. So because dialysis will control how much fluid is in your body, because it can control how much sodium is in your body, but most importantly, it controls what your blood pressure is like. We want to be able to limit and control the factors that are going to make that harder for the dialysis machine, right? Because at the end of the day, the harder the dialysis machine needs to work, the more tired you might end up being, and the more that you might have to need dialysis sessions. So just because you are on 3 days a week dialysis doesn't mean that you can just stay on 3 days a week dialysis. For some people, they might need to go to 4 days a week because of whatever reasons. So we try to limit everything that we can control to prevent having to do more dialysis. So really the name of the game is control what you can control, and a lot of that's going to come down to diet.
Also, to avoid getting to the hospital,
yes,
if you were to consume a lot of salt or miss your dialysis session for one reason or another, or miss your blood pressure medications and your pressure is high, you will end up in a random emergency room where there are random people taking care of you. They are trained health professionals, but you would rather get your dialysis in your dialysis unit and go home and have a good quality of life then be admitted to the hospital for something that you can control. What happens if you have any questions? Um, so as far as PD goes or hemodialysis, home hemo goes, once you have learned the process of the dialysis and your dialysis, your PD team, you have a PD nurse and you have a nephrologist. They're comfortable with you starting it on your own. All your supplies will be delivered directly to your home, and then you will be the primary person responsible for your own care. Of course, you can have your family member help you out, but you will be the sole responsible person for this treatment. You will never be on your own. Your PD nurse is available 24/7. Even if you get in-center hemodialysis, your nursing staff is available 24/7. You can call them at any time of the day or the night with any questions. Your team will check frequently on you, and you can call them anytime as well. Um, let's move to the next one. Peritonitis. It's an inflammation and infection. There could be sometimes inflammation, sometimes could be infection. Most of the time in the world of PD, we are talking about infection. Peritoneum is a very thin layer of membrane. It covers all the organs in the body. It has two layers. Between the two layers is a cavity. That's where your PD catheter is sitting in between those two layers, and that is where the dialysis fluid goes in, stays for a bit, and then comes out, because that is your dialysis filter, your natural dialysis filter inside your body. Now, what happens since this is a foreign body, the catheter is a foreign body, and then you are a human taking care of the catheter, there might be some times where you yourself introduce infection to the catheter, or maybe you did not intend to do it, it just happened by chance. The infection gets introduced through the catheter inside the peritoneal cavity, the fluid and the membrane gets inflamed and infected. How would you know it's infected? You would have pain, you can have fever, but the first thing that you might notice may not be the pain and fever. It might be the change in the color of the fluid that is coming out. The fluid that is coming out through the catheter is called effluent. The same fluid went in, dialysis, but when it came out with all the toxins and everything else from the belly, we call it effluent because it's coming out on its way, on exiting out of the belly. If you're able to read through your dialysis bag, the fluid is clear. If you are not able to read through that effluent bag, that means the fluid is what we call cloudy. Or sometimes you can see what we call fibrin. Fibrin are small fibrous particles which you might see in your catheter because the catheter is very clear, and you can see through the catheter. So you can sometimes see it in the catheter, or if you wake up in the morning, you will see it inside your bag. So we request our patients to check their effluent bag every single treatment. Do not allow children or pets when you are attached to the PD machine. Do not try anything different without asking your dialysis care team. For example, you're about to start your treatment, you're not sure, machine is giving you an alert, or you are not sure what's the condition of your catheter. You might think one of the seal is broken or something. Call your nurse. You would have their cell phone number. You can call them right away.
So some alternatives to dialysis, and this is one of the
Can
questions
I ask you
we got.
something?
Yes,
I
go ahead,
haven't
Dr.
I haven't
Batool.
before. Let's suppose it's you.
Sure.
You have to pick a dialysis for yourself. Which one would you pick? You know, our patients ask that question
Yeah,
many
that's
times.
true,
They
that's
ask
true.
me. They're like, doctor, if you have to pick one or the other, which one would you pick?
So personally, I would pick peritoneal dialysis. I think just the freedom of it, and then feeling like you're in control of it.
And then you can
I
travel
think-
all over the
yeah, and
world
you can
with
travel
your-
all over the world with the PD and the PD solutions. What about you?
I would pick PD for sure, for sure. Major reason is I think I can cheat on food. I told you guys eat the right food, but while you are on PD, we liberalize your diet in many ways, including the potassium. What type of food you want to eat, might be able to liberalize that a lot. Also, to give you an example, I have a patient who is on PD and went out of state. I was able to get his supplies delivered to his hotel room while he was there. And he somehow something happened and with his PD machine cycler while he was there. And the company who ships the machine, they shipped it to his room the next morning. So, and he had roommates with him, and they were able to sleep night quietly with him while his dialysis is happening, and he's there having fun in New Orleans, and he has all that. So,
So I'm sure many of you though are asking, that's all good and well, but any alternatives to dialysis? And I think that's a fair question, and I think this is a question we get, kind of often. Some people who are like I said, many of you either are or know somebody who's chronic kidney failure. You're kind of tiptoeing towards dialysis, and they decide, what, maybe dialysis is not for me. Is there any sort of different path? And so we just want to touch a little bit on these, just so we can kind of give you some insight about it. In most of the times, in most of your cases, your doctors are going to be doing what's called maximal medical therapy, which is basically doing as much as they can with medications that they can, right? So if you have high potassium, rather than doing dialysis, they'll try to give you medications to bring down your potassium. If you have really bad high blood pressure, they'll try to give you medications to bring down that blood pressure. But there are some things that really medications can only do so much. The biggest one would be what we say volume, or the fluid on your body, right? Because if the kidneys have shut down and the kidneys aren't making any urine, then we're not really going to be able to get that fluid out, no matter how much medications we give you, like furosemide or all those kind of fancy medications to make you pee. If your kidneys aren't able to pee, then we're not going to get that fluid out. Now, other patients, they hear this, they're maybe in a little bit more different situation, maybe a little bit more difficult situation. They want to pursue what's called palliative care. And palliative care is a whole other genre of medicine. Like I said, I don't want to go too down the road but it's people who really want to focus more on comfort and quality of life and quality of the remainder of their lives, rather than the length of life and the quantity of years.
Or if they have a disease process,
Yeah,
which kind of impairs them from coming to the
exactly.
dialysis unit. Number one.
Yeah.
Number two, if they have a life-limiting cancer or malignancy or a tumor, those are the discussions that we like to have as a team. And we do encounter those scenarios very frequently in inpatient as well as outpatient settings, and we like to take a multidisciplinary approach in those patients. Main thing is that once you see that your nephrologist is going to be right on point to refer you to a kidney transplant evaluation program, what I would like to iterate is that ask your nephrologist when is the time to refer you to a kidney transplant program. Please go get all your evaluations completed well in time, and so that you can get the kidney transplant when the time comes. There are some circumstances where their patients are able to get a preemptive kidney transplant. Majority of those situations we encounter where they have a living donor. They have somebody who is a family or a friend or somebody is willing to donate, and they just don't want to end up on dialysis. The alternatives to dialysis, medication management are there, but they are limited sometimes. And for a high functioning individual who has to focus on life or family or their kids, we do sometimes start hemodialysis sooner rather than later. And some patients, they just want to wait. I have patients, they were like, if I can be without dialysis for a week, I might as well. But the main thing you and us we can do is to get you ready, mentally and physically. And that's why we are doing this.
So just some takeaway points to hammer home. Like I said, and like Dr. Batool said, this is a mutual decision between you, your doctor, your care team, your family, your friends, about when is the optimal time for you to start dialysis. And like Dr. Batool said, some patients say, no matter what, even if it's a couple hours, I want to delay the dialysis. And others say, you know what, I don't want to end up on dialysis 2:00 in the morning because of an emergency in some ER in the middle of nowhere. So we like to at least start the conversation early on, so we kind of break the ice a little bit. The preparation for dialysis can start several weeks to months before you actually end up on the physical dialysis. And like we said, one of the most important things is to think about the nutrients and balancing fluids with regards to your health and getting the right amount of dialysis that you need. Now, some people, like we said at the very end, have the severe long-standing kidney failure, and they may not be the best candidates for dialysis in terms of their overall goals of their quality of life. So those people would end up opting for a different path. And we would encourage you to have these conversations with your care team early on so that we're all on the same page, and that at the end of the day, we get you as happy as you can be with whatever's going on. And like I said earlier, ultimately you guys are the coaches. We're kind of just the team members here, and you guys call the shots. So we just wanted to help kind of bring you guys up to speed with regards to dialysis as much as we could. We'll open the floor up now to questions, Amanda, if you can, and we'll go from there.
And again, I would say everyone who is here today is here because of a reason. Organ failure can be unsettling. It could be some of you might be afraid. Some of you are going to have a lot of questions after we finish this discussion. Please ask your care team. They will not know what questions you have unless you ask.
Very well put. Thank you so much, Dr. Batool and Ayoub. Very much appreciate your presentation. It was excellent. So if there are no other questions, we'll go ahead and disband. But if you have any questions, you can feel free to reach out to me or to go on the kidneywi.org website as well, because we do have some information available there as well.